You're listening to the RC Executive Lounge podcast, the show where healthcare revenue leaders share real-world strategies, hard-earned lessons, and bold ideas shaping the future of revenue cycle.
Hi, everyone. Welcome to another episode of the RC Executive Lounge podcast series. I am your host, Praveen. In today's episode, we are tackling some of the biggest challenges and opportunities in revenue cycle management with someone who has been right in the thick of it, leading teams, driving change, and delivering impact. We welcome Charles Frazier, a highly innovative leader in the healthcare industry, to our podcast series today. Charles Frazier is a Senior Vice President and Chief Medical Information and Innovation Officer at Riverside Health, an integrated health system in Eastern Virginia. He received a BA and an MD from the University of Virginia and did his family medicine training in the United States Navy. He joined Riverside's family medicine residency faculty in 1994 and is a clinical professor in the Virginia Commonwealth University Department of Family Medicine and Population Health. He has helped lead Riverside's electronic health record initiatives since the system implemented an EMR in its medical practices in 1996. A past president and a current board member of the Virginia Academy of Family Physicians, he has worked with a number of quality and informatics organizations and projects at the state level, including currently serving on the Virginia Task Force on Primary Care. We are glad that Charles is joining us today to share his thoughts on innovation in the healthcare industry. Charles, welcome to the show, and thank you so much for joining us today.
Hey, Praveen, thank you. Glad to be here. Appreciate it.
Awesome, Charles. So let's dive right in. With so many pressures on finance and RCM teams today, from payer delays to staffing gaps, how do you go about setting the strategic priorities for your organization when you look at it as priorities for the next 3 to 5 years versus priorities for the next 12 months?
Sure. Well, my perspective may be different than some of your listeners because I'm not a CFO. I'm not really a financial person. I'm a clinical person. But I am one of the officers of the company. And I do believe in the old saying that no margin, no mission. So it's obviously important for us to make our choices and decisions, in a fiscally responsive way. So I look for those things where we can improve health, improve clinical outcomes, but at the same time, that's a good business decision as well. And then obviously my other big priorities are trying to make things better for our clinicians, particularly our physicians and advanced practice providers. And so for me and the influence I have on our company, those are the things I'm looking for. But again, if we can find something where it's new business for us, it improves the health in the community, and it helps our clinicians provide that care, then that's a threefer, So those are the things I look for. Those would be some of the highest priority things on my list. So,
and you mentioned that your perspective would be very different. Actually, that is exactly the perspective our audience is looking for. When we are talking to an innovation officer, you obviously bring that lens of innovation with a balance of financial decision in partnership with your RCM teams. So your insights are extremely valuable to us, right? Along those lines, every organization has to make tough choices. These choices are even tougher when you're dealing with decisions of innovation, because your organizational team members, vendors, everybody is flocking with so many innovation projects all the time, right? Which basically means at any point in time, you're going to have a whole number of projects out of which you can only handpick a few projects. So can you share an example where you had to say no to a good initiative in favor of something more critical?
Yeah, that happens a lot. It's interesting because I had that innovation word in my title, but I got that many years ago because, we would want to do something or need to do something in our electronic medical records. We had more than one at the time. Couldn't do it. And so I'd figure out ways to do things. So I got that innovation title. In some ways, I almost feel now I'm the anti-innovation person because we're in an Epic shop. We started our Epic implementation about 10 years ago. And so now a lot of times people will bring ideas to us or platforms or solutions. And one of the first things we say is, well, did you check to see what Epic can do? Because again, we're paying for that. So if Epic can do it and it's integrated, that's it kind of makes more sense sometimes to use the solution, even if maybe if it's new, it's not the best thing out there. So what happens a lot is we say no to some third party solution because Epic has something that we're not using or it's coming soon and we should use that. But I mean, there are other things that come along too, and sometimes you can't make the business case for it very well. So it obviously doesn't make sense to devote a lot of resources to that. And some of them are great things. I mean, right now we're looking at some of the ones in radiology. There are a lot of FDA approved artificial intelligence radiology solutions. And it's kind of like, okay, but that's going to cost us $100,000, $250,000. And where's the return on investment? And sometimes you can say, well, it's a safety net, to help our radiologists. Well, that's great, but again, where's that money coming from? So we do say no to a lot of ideas that are proposed to us, although we do really try to continue to move on and innovate. So but it is a balance.
Makes sense. And every time we go to one of these RCM related events, be it MGMA, HFMA, wherever, we hear a lot about denial prevention. And denial prevention hurts patients as well as providers, but also we're being told by organizations that denial prevention is essentially not just the battle from the RCM team. It is actually an entire organization battle because everyone has to chip in their own way towards the RCM operations to reduce denials. In fact, as I remember, one of the projects that we're going to talk about in a few minutes from now, after the first break, is going to be focused on an implementation that had an indirect impact on denial prevention as well, right? So thinking about that and your own set of priorities within your organization in terms of innovation, EHR, EMR improvements, how do you keep that denial prevention lens in mind when you're evaluating these projects? Where does it fit in your priority list as an innovation officer?
It's high up there. One of the huge components of our financial challenges are the fact that payers, a lot of time, they don't want to pay you. They do deny payment. They delay payment. I mean, that's the way it is. That's just the truth. I'm not trying to speak badly of insurance companies, but that's part of their business model. And we know now too that they're actually implementing artificial intelligence tools to make them more efficient at doing that. And so it really does start, at the documentation level, at the coding level. I'm not just talking about coding from a level of service standpoint, but, diagnosis coding. We've got a big initiative right now trying to, at the point of service, trying to help providers know that diagnosis code that you just put in for that cancer treatment or that infusion treatment is not specific enough. And the insurance companies are going to deny that claim because it's not specific enough. And you, as a clinician, as a physician, I'm saying, well, how does that even make sense? How's that right? I mean, this patient needs this therapy that's for this cancer diagnosis, and the fact that the provider didn't put laterality on there or something, what is it? How does that change anything? It doesn't. And yet we have to address that, because if we don't, there's all this cost involved in trying to, resubmit that claim and make it more specific. And the coder can't go in there and say, oh, let me make it more specific in this way. That, the physician has to do that. So we're trying to do that up front. And that's one piece of it. We get denials for, hospital admissions, or is it an inpatient admission, or is it an outpatient in a bed or an observation? And can we get that right up front with the justification that's in the claim, so that, again, we don't have to keep doing that iterative process. And as a family physician, prior authorization for prescriptions. You know, and I had a call a week or so ago with the state looking at, you know, the kind of electronic prior authorization. And I told them, I said, you know, actually that works pretty well. That's not the problem. It's not the technical issues of actually getting that electronic prior authorization there. It's actually the business practices where once it goes in, it gets denied because, you know, it's January now. And you know they got a different deal on a medication so that you know, long acting insulin that the patient was on, they don't cover that anymore, so now we have to switch into another one, and then you have to then adjust it, you know, because it doesn't work the same, and then, you know, next year, guess what, they switch it back. Oh yeah, so all of that to say, it fits very highly into our strategy because it's such a waste of money, waste of time, effort, and money to basically get paid for what you do.
Makes sense. Charles, thank you so much. That's a great segue to our next segment where we're going to be talking about a very exciting project that you and your team had implemented for Riverside. But before we jump into the section, let's take a short break. We'll be back soon. Everyone, stay tuned. This is a very exciting project. You're going to get a lot of amazing information from Charles. Please stay tuned.
This episode is brought to you by rchq.com. That's ARCEEHQ.com, the Agentic AI platform helping healthcare providers improve financial performance by simplifying patient financing and financial assistance. From faster approvals to fewer write-offs, RCHQ makes it easier for patients to pay and for providers to get paid. Learn more at rchq.com.
Charles, let's dive right in to a recent initiative you led. I had heard a lot about this initiative when we met the first time, but I'd love for our audience to delve deep into the details here. So maybe let's start with what was the challenge that you and your team were solving for with this specific initiative? Maybe you can introduce a little bit about the initiative and talk about the challenge.
Yeah, I'd be glad to. This is one of the most satisfying projects or initiatives I've ever worked on. And I've been doing medical informatics stuff, as you said in the introduction, for almost 30 years. And that was ambient artificial intelligence, or ambient scribing. And you know, the challenge we were solving for, you know, it has to do with provider burnout. But I mean, the real challenge is just the change in documentation requirements and the change in you know, coding for payment and stuff that's happened over the years. You know, and from the get-go, I believe that, you know, electronic medical records were a wonderful opportunity to document the care that you provide, and then to use that data to take better care of patients. But over time, it really became a burden, because to be able to get paid for what you did and to document the complexity of the care that you were providing and to prove that you were providing the quality that you were providing, you know, the medical record became a lot more than just, you know, a note to say, okay, this is what the patient came in with, this is what I think is going on, and this is what I'm doing. And so over time, the notes got very complex, but the amount of work, the administrative burden just to do that documentation became overly burdensome. And not only that, not only was it bad for the provider, but the patients didn't like it either, because I've heard many times, and you probably experienced it yourself, but I've heard patients say, you know, that doctor or that provider spent more time and paid more attention to the computer than they paid to me.
Yeah.
And so we wanted to do something about that. We wanted to reduce at least that one, you know, it's got nothing to do with denials or filling out, you know, Family Medical Leave Act forms or some of these other burdensome things that doctors, you know, have to deal with. But if we could deal with that one issue of the documentation and make that easier, then we wanted to do that. So that was the challenge we were trying to solve.
Makes sense. And once you identified this challenge, obviously there are a lot of solutions out there. There are a lot of vendors out there. Is there a specific criteria that you looked at in order to say, okay, here's the right solution for us, or here's the right vendor for us? I think a different way of asking the question is, how do you go about typically evaluating a vendor or a solution for a problem of this scale? This is a highly complicated problem that you're talking about. And choosing something like ambient AI, it's not an easy decision, especially for someone at your level, right? So
Right.
how did you go about with this decision of choosing a solution or a vendor?
Yeah, well, first of all, it's got to work. And so, when I first heard about this, was back in like 2018, and a vendor, actually one of my coworkers said, "Hey, there's this company, it's got this thing, and it listens to your conversation, it'll create your note for you." And we were like, "That's awesome. Let's see it." And the vendor came in, and it didn't do that at all. It was basically like a personal, digital assistant. You could tell it to find the last chest X-ray. It would sit there and kind of take a little while, but it would find it, pull it up in the electronic health record. And I remember telling them, I said, "How about this thing where it listens to you and creates the note?" And they said, "Well, Dr. Frazier, that's really complicated." I go, "Yeah, it is." So that it's got to work, and it didn't work. And so we checked with that company, annually, and it was kind of waiting for them to do it. And then actually, as generative AI really developed, then there are multiple vendors out there that can do that and do it well now. So then it becomes more like, okay, if they're all doing it and they're all doing it pretty well, then what's the differentiator? And really, I think the differentiation is what platform or platforms best integrates with your electronic health record. Having done informatics for 30 years, without a question, the more integrated it is in your electronic health record and the more integrated it is in your workflow, the more successful it's going to be. And I know it from experience, because we used to be more of a best of breed kind of organization. So we had a different EMR in the physician offices, different EMR in the emergency department, different EMR in the hospitals, different EMR in the nursing homes. And we were really good at interfacing those records, but it didn't work because it wasn't integrated. You need an integrated record for an integrated system, where you got all that functionality integrated into your workflow. So for us, we basically looked at two vendors that were most integrated with Epic. And then we ended up choosing one called a Bridge. And at that point, it's like both of these work well. We talked to different people that were using it, and they were being successful with it. Their providers loved it. But at that point, it became like, which one feels better to us? And both of those were good. But a Bridge, we thought, we just like the two things particularly stood out to us is we like the interactions we have with the CEO. He's a cardiologist. And the other thing was their large language model was developed, more it was trained more on medical documentation versus trained out on the internet, kind of out in the wild. We kind of like that. It just seemed a little bit more kind of secure and isolated. And so to answer your question, finally, we kind of looked at all of that, but at the end, it was like, okay, we got two good partners here. Which one do we kind of feel better with? But I think either one of those would have been, good solutions, but we ended up choosing a Bridge.
Makes sense. And let's talk about implementation. When you're implementing a project of this scale, there could be pitfalls or surprises along the way, right? Could you share any lessons on the pitfalls or surprises that you and your team faced when implementing this project?
Well, the way it works is that, you actually, well, I'll back up. One of the first things we had to do, we had to develop some policies, because there's like, we're kind of developing them as we went along. It's not like you can copy a lot of stuff, because a lot of folks don't have policies. So, but we had to determine like how, are we going to get the patient's consent? We decided, yes, we're going to get the patient's consent. But the implementation went smoothly. We set up a process where, the providers, we said, okay, here are your requirements. This is what you are agreeing to do. You have to review every note. You cannot just rely that it's going to do it right, because it'll make mistakes sometimes. You got to review every note. You got to get the patient's consent. You need to put something in your note that, that mentions that consent was obtained. And then we had some volume type requirements in there too. Like if we're going to pay for this, then you need to use it for at least 80% of your notes, those kind of things. But no really pitfalls there. I mean, really, it's gone amazingly well. I mean, we have had some issues sometimes where either the vendor updated something and we had a little bit of a hiccup. We've had some issues where we're trying to figure out what's going on, and we made some change in our network that blocked something, some of those kind of things. And and then sometimes we have some network Wi-Fi issues, and we've actually gone out and strengthened some of our Wi-Fi networks and some of our practices and those kind of things. But it's gone amazingly well. We've had literally a handful over, out of hundreds of thousands of notes created, a handful of patients that complained because they didn't feel they actually gave consent. So we had to go back and kind of change the way we, very specifically get their consent, and so that they know we're talking about an artificial intelligence application. And it's been fantastic, and really we had very few issues in our implementation.
Makes sense. And for this project, what has been the measurable impact after implementing? Like looking back, before and after, what has been the measurable impact?
It's been pretty positive. So I'll just go through a bunch of things. First of all and foremost, I mean, we started off with the pilot. We did 30 providers for 60 days, and we surveyed them before they started and 30 days in. And one of the things in that survey was a tool that assesses burnout. I think it was called a mini-Z tool. And so pretty much like national averages, 61% of those providers had some degree of burnout or expressed some degree of burnout before they started. 30 days in, that dropped down to 27.7%.
That's amazing.
So cut it in half or more. And that's what really got us thinking, like, you know what, we have got to do this, no matter what. This, burnout is we already had programs to try to address provider burnout. And we said, this is amazing. We need to do this. So that's what really drove it forward. But, we've seen the sort of outcomes that you would imagine you would see, a 15% decrease in time and notes, the notes activity in electronic health record per day. If you look at it per encounter, about a 17% decrease in the time they're in the notes activity, creating their notes, et cetera. We measure pajama time. That's the amount of time people spend, at night or on weekends. And some of that is what providers want. They want to get finished with work, go to their kid's soccer game, and then finish their charts at night. Now what we're seeing is there was a 7% decrease in pajama time, but what they're telling us now is they actually spending that time in the evenings, to the extent that they do that, actually preparing for the next day.
Amazing.
And you can use the Ambient AI to do that. You can review the chart, have it record that, pause it, and then when you're with the patient tomorrow, you start it up again, and it puts it all together. So, but the wait time for providers went down by 2 minutes per encounter, which doesn't sound a lot, but if you're seeing 25 patients a day, that's almost an hour, right? And the patients like it. They like it, I think, because maybe some of that wait time went down. But the other thing is that, again, I said patients used to complain that doctors spent more time looking at the computer than they did them. They don't see that now because the documentation is being captured. The provider is just looking at them. So we saw our patient experience top box scores go up by 3 percentage points. That's not relative. That's actually 3 percentage points. And the impressive thing was it started off at about 85 and it went up to 88. So we started off pretty high and it went up even higher, which is kind of hard to do when you're up that high. The feedback I've gotten from providers has been amazing. I won't go through all things, the kind of messages, but the phrases they use are game changing, practice changing, magical, life changing, those kinds of things. And then the documentation is more complete because it's capturing all the information that you're going over with the patient. It's capturing the breadth of that clinical discussion. And then when you're reviewing that note, you go, oh yeah, that's right. We talked about their COPD. We talked about this. We talked about that. So we saw a 15% increase of the number of diagnoses per encounter. There are these special diagnoses called ACC diagnoses that actually kind of it's kind of risk adjustment factor coding. We saw a 14% increase in them. And then because of that breadth of the clinical documentation, there are times when the level of service gets shifted up to the next higher one. And so, for example, with established patients, just as an example of this, typically most visits are level 3 or 4, and then you have some level 5s, but the level 4s went up 4 percentage points, which again doesn't sound like a lot, but that's huge because that's where your biggest numbers are. And so if you look at it from a work RVU standpoint, those went up about 11%. And then we did a net revenue increase because I didn't know. Work RVUs go up, but that means we're paying the providers more too. So what does that mean for the organization? And I'll just put it this way: the increase in net revenue per encounter was about double of what we were paying for a bridge. And then as we expanded that and the per provider costs have come down, I would say it's more probably like a 4-to-1 return on investment. So, and then the last thing I looked at here recently was, okay, if it's making this kind of faster and easier and they're not spending so much time on documentation, what has it done with their volume? And that's hard to determine because there's so many different confounders there. You got people on vacation and you've got new providers that are building their practice. So I looked at established providers that have been here at least 2 years and looked at their numbers before they started using the Ambient AI and after they started using Ambient AI, and it went up 7.9, basically 8%. So they're seeing more patients. They're, more complete documentation, more diagnoses, more revenue. They like it. The patients like it. The outcomes have been pretty astounding.
These are very impressive results, Charles. Thank you so much for sharing these results with our audience. With that, let's take a short break. When we come back, we are going to hear about Charles' perspective on innovation, innovative technologies in the market, and leadership. Please stay tuned.
The RC Executive Lounge is proudly sponsored by rchq.com. That's ARCEEHQ.com, where Agentic AI is transforming how providers manage patient payments and financial aid. Providers using RCHQ are seeing more collections, less manual work, and greater access for patients in need. Visit rchq.com to learn more about the platform and schedule your personalized demo.
All right, let's dive right back in. So I want to shift gears a little bit into technology. Now, there's been a lot of talk about agentic AI and AI in general in revenue cycle, as well as innovation in healthcare management. Being the innovation officer, what role do you see agentic AI playing in revenue cycle or in general in healthcare innovation? And how is your organization looking into implementing agentic AI?
Sure. I do think it's going to be important as this technology continues to improve. I'm not sure it's quite there yet. I mean, I don't know if you've had an experience where you talk to some AI agent or communicate it with them and thought, oh, this is fantastic. I mean, a lot of times you kind of get to a place where you're like, I just need to talk to a human. Let me talk to a human. So, but if it's not there, it's going to get there. So for us, I mean, there's so many aspects of it. So first of all, it could be from a revenue cycle standpoint or a volume standpoint. It might be an agentic AI chatbot or something on our website that if they're looking for, a particular type of provider or a particular type of care, we get them to the right place and help them, get an appointment scheduled. We are definitely looking at it from a scheduling standpoint. We do have direct scheduling where a patient can go on our website and create an appointment. Again, we could help them get to the right place, but we have call centers too. We have several call centers. We actually have Riverside Nurse, which is a registered nurses where anybody in the community can call in and ask the nurse a health question, right? So we're not looking to put an AI agent there yet, but we also have scheduling call centers. And so, for example, we're looking for, I think where we'll probably try this first in there is in our gastroenterology call center. So that's where patients call in and they're trying to get their colonoscopy scheduled or particularly. And we've had some challenges, keeping personnel, training those personnel. We have problems with drop calls, a high abandonment rate, high wait times. And so we can get a voice-based AI agent to take those calls and sometimes maybe get them right, maybe get them scheduled. But other times, if not, do a warm handoff to a human. So that's probably where we're going to try this first. And we're looking at a few different vendors and doing demos and calling up, doing cold calls where they actually say they have an agent now. So we'll do that. And then on the kind of more purely rev cycle, and this probably be more text-based, but if patients have on our patient portal have questions about their bill, have the agent, AI agent actually answer those questions, or try to do that initially before they actually get transferred to a billing person in the billing office. So that's kind of what we're looking at now. Nothing, I guess the same thing everybody else is looking at as well. It's going to be interesting though, because with Epic, my understanding, and I kind of keep abreast of this, I try to keep abreast of it, is that some of the more text-based things, I think they will have, or they have now solutions and will have more solutions with that. I don't know that they're going to have the voice-based things for a little bit yet. So we're looking at, some third parties for that. And then, we're looking at it in a way, if we're going to do that, then it's got to be risk-based. So they have some skin in the game too. And it has to be short-term, relatively short-term, no 3-year contract, 2-year contract. It's got to be like a year contract and some very, specific termination language in there so that we can get out of that contract if and when it's time to do that. So, but yeah, those are some of the things we're looking at right now.
Makes sense. And are there other interesting technologies in the market that you and your team are actively looking at other than agentic AI?
Oh, absolutely. Yeah. Again, there are multiple radiology type FDA approved AI models. And again, we would like to use some of those, but the cost is going to have to come down. It's kind of just, it rubs me the wrong way that for some of those solutions, you're sending your images to them, right? And they're doing whatever they do for their FDA approved model. But you also know that they're using your images to train their next model. But they don't seem to want to give us any kind of credit for that, from a pricing standpoint. That doesn't seem right to me. But I think there's some wonderful opportunities for that going forward. One we're actually we just signed a contract for, and we're going to roll it out to about 8 practices. It's looking at actually basically fundoscopic, eye pictures of the back of the eye. And the AI actually reads the back of the eye, the fundus, to look for diabetic retinopathy.
Wow.
And you get the answer right then, and it's in the primary care office, and you can bill for that. And then if they have retinopathy, then you refer them to your ophthalmology colleague. So that does multiple things. It's great for the patient because you're getting them screened. It's good for the primary care office because they can bill for it. And also, a lot of times we have value-based kind of programs where if we get the screening rates up, that's a good thing. But it also opens up slots in the ophthalmology office because we're doing that screening instead of them having to do it. But then when we refer to them, they're getting the patients that really need the ophthalmology care for their injections or whatever if they have retinopathy. So we're kind of excited about that one. But really what I'm very excited about, and this is going to come soon, is taking the ambient AI, and there are some, I think in the very near future, that's going to evolve to the standpoint where it's going to listen to the conversation and will actually serve up your diagnoses for you, specific diagnoses too, for the risk adjustment scoring, HCC diagnoses, and also based on what you said, the orders. And then you could look at those, like, yep, that's what I want, and pull those right over. Because right now you have to enter all that stuff, right? But what I'm really looking forward to is it listens to the conversation. AI summarizes the chart, including external documentation, and then it looks at the evidence. I'm not talking on the internet. I'm talking about curated evidence, medical literature evidence. And then it says, hey, Dr. Frazier, did you think about this treatment in this patient? Because we can't know it all. I mean, if as a physician, if you read articles all day, every day, you still can't keep up. It's just the knowledge is evolving too fast. And so, combining that ambient AI, some of the, coding and diagnosis and some of the RCM stuff and, denials and all that stuff. And then, combining that with the medical literature to help guide you, provide the very best care for that patient. I think there's some real opportunities there. And
Thanks,
by the way,
Ars.
physicians, I'll just say, physicians will then say, well, how long are they going to need us? And the thing is about that is that, my answer is for a long time, because the AI can look at guidelines and it can look at the evidence, but it takes a experienced clinician, in my opinion, that, I'm biased, obviously, to say, yeah, for that diagnosis, this is the best thing to do, but not in this case because they have this other diagnosis or these two diagnoses, and the evidence is conflicting with each other, and you have to balance out the risk and the benefits. Now, can an AI agent or an AI platform do that? I don't know. Maybe at some point, but I wouldn't trust it right now. So.
Thanks, Charles. Let's take a short break. When we come back, we're going to hear from Charles about his perspective on leadership challenges in the healthcare industry.
Today's episode is sponsored by rchq.com. That's ARCEEHQ.com. If you're looking to reduce friction in patient payments and increase access to financial assistance without overwhelming your revenue cycle team, RCHQ's Agentic AI platform might be exactly what you need. Head to rchq.com to learn more.
When you're looking at projects of this scale, obviously change management is really hard. How did you manage change in your organization when you're rolling out this project?
I think in general, I would say what I'm dealing with right now is trying to kind of just tamp down the change a little bit. About a month ago, I realized that I really needed to communicate more about artificial intelligence. I thought seemed like every board meeting, medical group board meeting, every meeting I was in, I was talking about AI. I said, I'll drive these people crazy. But then I realized there were people sitting around white papers about AI. You have your colleague who had a buddy in college just had some startup and said, hey, I got this great AI use case. And then of course the vendors, I'm getting a dozen emails a day about some AI thing. And well, everybody else in the company is getting the same thing. So then they're sending them to me. And it's like, hold on, we're already working on a lot of this stuff. We got all these use cases that either we have live, we're working on or they're on the very, soon roadmap. And so I actually started about a month ago. I guess I've sent out 5 of them now. A week, Dr. Frazier's weekly AI blog, just to let folks know, hey, these are all the opportunities we have. These are good, safe use cases, and this is what we're working on already. And it's been pretty successful. It's really tamped down on all the emails coming to me asking me about different AI things because they know now what we're working on. So that's not probably going to answer your question very well, but it's really kind of managing the overall change that just because artificial intelligence is such a hot topic right now. And by the way, one of those blog entries talked about, some of the risks and some of our governance and some of our risk mitigation around it, the artificial intelligence as well.
You're talking about information propagation in the organization using a blog. That totally makes sense. As you look forward, if you were to give one piece of advice for someone who's playing a similar role as you in another healthcare organization, an informatics and information innovation officer in another healthcare organization, what would that be? Or in general, to another person in a C-suite in a healthcare organization, what would your one piece of advice be?
I think the first thing you need to answer is what kind of an organization are you going to be? Are you going to be on the bleeding edge? There's some risk to that. Or are you going to lag behind? And I don't mean that in a negative way, but are you going to kind of hold back and be conservative and kind of see what others do and try and that kind of stuff? For me, and I think for us, we want to be in the middle there. We want because we don't want to be out there on the front and you have some bad outcome and the next thing you know there's a lawsuit because you implemented some AI platform that had some bad bias in it that caused some issues or discrimination or something. So again, we're looking at there's plenty of opportunity with the artificial intelligence use cases and functionalities through our own electronic health record vendor. And we're already paying for that. So why not look at those first before we look too much at some of the third-party vendors, unless it's something the EHR vendor doesn't do or there's some specific use case that you make a good business case for. So, but first thing you have to decide is what kind of organization are you going to be, and then that's then how you set your strategy to implement this stuff. So.
Makes sense. Last question for the day. Is there a recent book, podcast, framework, even a TV show that has influenced your leadership thinking and how you approach situations that require strong leadership presence in the healthcare industry?
I don't know, not really. Again, I'm, as Bones McCoy said on Star Trek, I'm just a doctor, Jim. But I did read a book recently that I really enjoyed. It's not a new book or anything, but it was called Ice Diaries. It was by the second commanding officer of the USS Nautilus, which was the first nuclear submarine that the United States built, which was a very successful vessel, but it actually talked about their trip under the Arctic ice cap. And it was just such a great example of teamwork, training, resiliency, communication. And we need all of those things in this complex healthcare environment that we're working in and trying to lead and work with a group of great, highly trained team members, right? So I don't know, as I read, I just drew a lot of parallels to the healthcare industry and some of those properties that crew had at the same kind of talents and that we need to have as a team as well. So, but if you haven't read that book, Ice Diaries, it's a good book. So.
Thank you, Charles. Thank you again for sharing some very valuable insights today. I know our listeners will walk away with a lot of very practical takeaways and really a lot to think about. So thank you. This was a wonderful session today.
Well, you're welcome, but thank you for having me. Appreciate it.
To our audience, thanks for tuning in to the RC Executive Lounge podcast series. If you enjoyed today's conversation, be sure to subscribe on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And if you would like to be a guest on a future episode, head to rchq.com and look up the Revenue Cycle podcast series link to learn more. Until next time, I'm Praveen, and this is the podcast where RCM leaders lead the conversation.